Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. Happy to have you today, and each Tuesday I look forward to bringing you the latest in what's happening in healthcare and different platforms. Today I want to discuss what I actually wanted to discuss last week, which is medical decision-making versus medical necessity. As I'm preparing materials for the on-demand 2021 new E&M rules that, by the way, is out. So if you want to order it, you can get it on my website at terryfletcher.net. But I'm also up to my eyeballs in audits this month with the current documentation guidelines that we're using now, and then also what you're going to be seeing in 2021 in just 6 short months. It's important that you know the difference so you'll be able to reconcile the new rules for next year. And what you may think you know may surprise you, because I'm seeing that there's a lot of practices, a lot of coders, a lot of physicians even, that just don't understand there is a difference, and they try to use them interchangeably. So let's get started, and it is medical necessity versus medical decision making. And I just want to talk to you about it because there is a difference. So medical decision making specifically refers to the complexity of establishing a diagnosis and or selecting a management option for a patient. Medical necessity refers to the appropriateness of the service provided for certain conditions. So medical necessity determines whether the service will get reimbursed. Again, you're going to hear me talk about money a little bit, only because the nuance of money is really put in to the Medicare Act and the Social Security Act without you realizing it's there, and I'll show you where it is. So problems can arise with training and documentation, and again, with the 2021 guidelines coming up, and also what the guidelines currently say, but they can come up when medical decision-making and medical necessity are used interchangeably, or when practices and payers defined medical necessity differently as well. So first, let's look at medical necessity. So AMA defines it as healthcare services or products that a physician would provide to a patient for the purpose of preventing, diagnosing, or treating an illness, injury, disease, or its symptoms in a manner that is, they say A, in accordance with generally accepted standards of medical practice, or B, clinically appropriate in terms of type, frequency, extent, site, and duration, and C, not primarily for the economic benefit of the health plan and purchasers or for the convenience of the patient, treating physician, or other healthcare provider. And this is an important context or important way to look at things from the AMA definition, mainly because you're going to see a word that's used in the 2021 guidelines, and it's called addressed, and it's used quite a bit. And so when you talk about, even just looking back at number C or letter C, it says not primarily for the economic benefit of the health plans and purchasers or for the convenience of the patient, just stopping there. So just because a patient wants something, there has to be a medically necessary reason to be able to give it to that patient. So it can't just be for their convenience or because they say I saw it on TV. So Medicare also has chimed in to the medical necessity definition, and they put it in the Social Security Act under Title XV11 of the Social Security Act, Section 1862 AIA. See, I find my rules. So if you ever have to look at them, you want to make sure that you have that chapter verse. And it says, and I'll quote, it says, no payment, see the money thing again? No payment may be made under Part A or Part B for expenses incurred for items and services which are not reasonable and necessary for the diagnosis or treatment of illness or injury, or to improve the functioning of a malformed body member, end quote. And so when you look at this, it's kind of interesting because they mention money, and so payment, and then they're talking about reasonable and necessary for the diagnosis or treatment of. Well, to get there, that requires some kind of a history and exam, otherwise you wouldn't know what they needed. Also, in the Centers for Medicare and Medicaid, the CMS Internet Manual, so they call it the IOM, Internet Only Manual, Medicare Claims Processing Manual. This is in Chapter 12, Section 30.6.1. This actually goes on to talk about medical necessity as well. And this says medical necessity of a service is the overarching criteria for payment, money again, in addition to the individual requirements of a CPT code. It would not be medically necessary or appropriate to bill a higher level evaluation of management service when a lower level is warranted. The volume of documentation should not be the primary influence upon which a specific level of service is billed. Documentation should support the level of service billed. So we'll get into that as far as looking at it from an EMR perspective, because we know our electronic health record can populate fields, which can be a problem. But one thing I've noticed is that neither Medicare or the AMA or really any other payer that I've looked at their guidelines, they really haven't developed guidelines that describes the medical necessity for performing a specific level of history or exam for a particular presenting problem. So, for example, if you've got cardiovascular disease or chronic conditions of diabetes or hypertension or anything like that, it doesn't say it needs a detailed history or a comprehensive exam. So it's really what the physician feels is appropriate, and then that's how they're basically getting to the medical necessity of their now medical decision making. But if a medical provider documents a detailed history and a detailed exam, should a payer or even a coder say that that wasn't needed? So we have noticed in the upcoming changes, AMA has adjusted the scoring to include of the history and exam, and they basically say they're not going to use that in leveling of a code. So Medicare said the same thing. That's going to be just inclusive of the medical decision making. But the thing is they have not omitted the need for a medically necessary, again, medical necessity, problem pertinent history and exam, as some have thought. I've heard people say that it's gone, and it's not. But the medical necessity, let's say for ordering an EKG or a CT scan of the brain, is clearly listed in medical policies. So they'll tell you what you have to see within the presenting problem and then why you can order it. If the patient's going to have an extremity vein ablation, for example, there are clear diagnostic indications to separate out cosmetic from medically necessary services, and policies need to be read, understood, and adhered to. But medical necessity is the concept that healthcare services and supplies must be necessary and appropriate for the evaluation and management of any disease, condition, illness, or injury. So the care must be considered reasonable when judged against other current standards of medical care. So here's an example of medical necessity. I almost said the wrong thing there. So an established patient comes in complaining of intermittent chest pain and occasional shortness of breath. So it would be medically necessary for the physician to perform, the provider to perform, a comprehensive history to address this issue. First, the provider would take an extensive history of present illness. They'd want to know the location, the severity, the duration, any modifying factors, and then, of course, any associated signs and symptoms related to the patient's chest pain. The provider would then review and confirm the patient's past medical history to identify any potential risk factors for coronary artery disease. Maybe they have hypertension or dyslipidemia. And then the physician would hopefully also ask about the family history of cardiovascular disease and perform a social history to determine if the patient maybe is a smoker or leads a sedentary lifestyle. So you can see all of those things will help make a case for that medically necessary service. And then finally, because the clinical spectrum for diagnosing chest pain is pretty broad, the provider performing a complete review of systems is now also justified because they could uncover any clue that may point to a diagnosis for them. As the etiology of the patient's condition is really unknown, sound medical practice now could also merit an 8-system physical exam because the physician needs to figure out that definitive diagnosis towards a treatment and plan. If the EKG was performed at the encounter and was abnormal, then it was determined that the patient needs to be scheduled, maybe let's say for an immediate cardiac cath for suspected coronary artery disease. And let's just throw in that the patient's also diabetic and is on anticoagulant medications such as Coumadin or something, which would have to be adjusted prior to the procedure. The patient has hypertension and was recently diagnosed with early onset osteoporosis. Do you see how I'm building my case here? The EKG performed in the office, again, was abnormal. So therefore, the medically necessary comprehensive history, detailed or comprehensive exam, and the medical decision-making of high complexity, because the patient also has high risk factors, would support that 99215 for that encounter if that was an established patient. But be aware of over-documentation. So you may see, especially for those of you that are auditors listening to this, you may see provider documentation that's always detailed or always comprehensive, and levels of history and exam always seem to be really high. Well, that's where it becomes kind of problematic with electronic medical records, because not only does it make it easier to document, or it can be the provider's standard of care that, maybe includes all that, but you need to be careful because sometimes this is a click and paste your way to a higher level of service. And when I'm looking at this, one of the things that gives me basically an auditor's, I don't want to say insight, but an auditor's kind of an instruction that you can look at the medical necessity of the documentation, because when we look at the Medicare claims processing manual that I read to you, it says that the volume of documentation, is not the overarching criterion for that final level of service. So even if you have a ton of information, you can actually say, but this wasn't necessarily problem pertinent. It's not justifying that higher level of service because it doesn't support it. I think I mentioned in one of my podcasts recently that I've got ankle physicians, foot and ankle doctors. I've got other specialty physicians that know that their exam will never get them to a higher level of service. So they throw in, HENT systems, or they throw in GI or GU systems to look at a patient who's coming in for ankle pain. You can't do that. And they say, well, I need to look at everything. No, not according to Medicare and the American Medical Association. So who is your watchdog? And CMS and AMA has jointly developed that documentation guideline that, again, that's why they say 2 out of 3 for established, but you have to reflect that medical necessity is the overarching criterion and not just for the medical decision making. So it depends on how you get there and how you can reflect that. That's where I think we're going to have a problem in 2021, because they're saying that you only have to have a problem pertinent history and exam to be able to support your code. Okay, well, how extensive do you need to be to support the medical necessity of the service? Because those rules are not changing. Then we flip the switch to medical decision-making. So to justify an E&M code level, the history and exam and medical decision-making must be medically appropriate. Okay, and this is going to be a huge concept to grasp in 2021, because in 2021, it's either going to be based on time or medical decision-making to choose a code. And remember, the time has been changed to ranges instead of just typical time, and they've been increased. So what your physician thought used to be the time for a certain visit is actually increased. But if your clinician documents no solid evidence of medical necessity, it would be considered a false claim to report a higher level of service. Such a claim would not be reimbursed or should not be reimbursed and could be asked for a refund, regardless of how severe the patient's condition is and how complicated the provider's thought process was, if the medical necessity is not established or fully supported. So the current documentation guidelines that I use right now, either 95 or 97, that's a joint work product of Medicare and AMA. And those guidelines were established to try and reflect that not only medical necessity, but to get to a medical decision-making, history exam and the medical decision-making must be met. But there's nothing in CPT or CMS that says medical decision-making must be one of those components. Now, what I do look at is I believe it should be, but it's one of those things that it reflects, how did you get there and why are you doing it? Sometimes I will reverse my audit and I will look at medical decision making, and then I'll go back up to see how did they get to that medical decision. Because if they're ordering tests and ordering a bunch of things, but I don't see the reason for it in the history or in the exam, then I will not only possibly query a physician, but I'll discount what's in the note. The quality of E&M services and documentation is really important for the provider reimbursement. Again, now we're talking about money again. So problems can arise when you're not understanding how Medicare is addressing the payment portion or the reimbursement as it's tied to medical decision-making versus medical necessity. So medical necessity drives the final E&M code choice, not the medical decision-making by itself. So for every encounter, let's say now in 2020, documentation has to show those levels of history and exam and medical decision-making, but they have to reflect that they were medically appropriate and necessary if you order any ancillary studies, therapeutic interventions, anything like that there was a reason to do it based on the presenting problem. So we have to make sure that when we're applying that medical necessity definition, that we can get to the medical decision-making based on that. There has to be a correlation between the provider's thought process and the workup decisions, such as ordering medication, any kind of imaging, diagnosing, and all of that, to the presenting problem to get to the medical decision-making. So for an example, this is one recent one I had. Patient presents with sign or symptoms suggestive of gallstones, but the exam elements are general exam, eyes, ears, cardiac, and neurological. There's no GI exam, and I thought I missed it, so I went back to look again, and it's not there. And the review of system part of the history does not support any problem pertinent positive, suggestive of gallstones in the diagnosis. Then the medical decision-making states that an abdominal ultrasound will be ordered for potential cholelithiasis. So how did the provider come to that medical decision based on the supporting documentation? So now you can ask the question, where is the medical necessity? There's no clinical medical necessity for the order of that ultrasound and to make it to the medical decision portion of the record. So the level of service cannot be established or supported. And at that point, I would query the provider. I would basically say, where did the order for the abdominal ultrasound come from? I wouldn't say, did the patient have present with gallstones? You can't lead a physician into what you want them to say. You have to make sure that they come to that decision on their own. But medical decision making can be used as a weight against the physical and history and physical exam in determining the level of service. But again, as we get closer to 2021, medical decision-making is important, and the role your physician has to determine is, because the one word that they use all the time is what is being addressed. So how do you determine medical necessity and how do you get to medical decision-making? Because what the patient came in for, the presenting problem, led up to what you ordered, reviewed, performed, or addressed. And that's really how you get from one place to the other. So realize that even though there is a medical necessity to get to the medical decision making, they're not equal to each other. They're not used interchangeably. And again, to read up on some of these, some of this information, to make some conclusions on your own, go to the Social Security Act, Section 1862, and also Chapter 12, Section 30.6 of the Medicare Services Internet-Only Manual. It'll really help you to understand this concept. You're going to need it for next year, and I just want to make sure that you have it now so that you can apply it to what you're looking at, and then you don't have to really relearn something else in addition to your new guidelines. Today's topic was brought to you by Formstack, a secure workplace productivity platform built to produce solutions to the everyday work that slows organizations down. Formstack is a data collection and management tool that allows you to build forms and surveys in minutes and store your submissions in an encrypted database. If you're looking for a hassle-free way to revamp your data collection process, look no further than to Formstack. Visit formstack.com/codecast to learn more and sign up for a 14-day free trial of their solution. Again, formstack.com/codecast. Okay, so my coding question kind of goes along the lines of making sure that you understand the difference between modifiers. And so a question came in from one of my Coding Corner clients, actually out in Kansas. It says, Terry, we are having a discussion here in our billing office, and one of my coders says that we need a modifier in all X-ray codes regardless of the situation. I think, however, that there are some instances where you don't apply a modifier to an X-ray code. Who's right? Okay, so you're right. There are certain times when you don't need it. So many X-ray claims might get a 26 modifier. They might get no modifier at all, and they might get an RT or LT, right or left, to show the laterality depending on your payer. But it's really got to do with place of service and ownership of the X-ray equipment. So if your physician or the facility where your physician works has its own X-ray equipment, you report the code without any modifiers because you're billing globally. So for example, if the physician conducts a 2-view knee, then you report 73560, which is radiological examination, knee 1 or 2 views, and you wouldn't have a modifier. But if the physician performs the same x-ray, let's say in a hospital using the hospital's equipment, and your physician is on staff to read the x-ray, let's make that clear, it's not a radiologist at the hospital, then you could report 73560, so the same code, but with a 26 modifier, because then they would be billing the TC modifier. But don't bill that if it's an overread. So the patient had x-rays, let's say in the ER, and then they're coming to your office, and now you're, reading them again. That's just part of your medical decision-making process. And so that's not part of something you can bill for. But if your physician is the one that's hired to do the reads at the hospital, then you can code for that with a 26 modifier. So anyway, your other coder was incorrect, that you don't need it all the time. You want to check with a payer. Also, make sure if you're using the RT and LT for right and left side of the body, make sure that one of those services doesn't have a bilateral option, because if there is, then you want to make sure that you're using that instead. So for example, on the knee x-ray, there's a bilateral option only for standing anterior-posterior for both knees. So the patient's standing and you're looking at the front and the back side, then you would only code one code. But if you're actually doing a 1-to-2 view for right and left knee, you may have a payer that wants the RT, LT also. Okay, so your coding question was brought to you today by Modern Healthcare Magazine, an award-winning healthcare business news, research, and opinion, modernhealthcare.com/subscribe. Also, one thing I do like about Modern Healthcare, for those of you that are looking for publications like I do that really are credible and have some good information, they have these new 15-minute video chats every Monday called The Checkup. I really like them. I might do some myself. And the last one I listened to was a conversation on managing skilled nursing facilities and nursing homes from one of the owners of one of the, I don't want to call them franchises, but one of the companies that's renowned for skilled nursing facilities, and how they're dealing with the pandemic. And it's very interesting on their struggles and protocols when they get sent patients who are coming over as positive. And so just something to keep in mind as you possibly look at that platform as something you might want to subscribe to. It's $15 a month, and I think it's worth every penny. I get a hard copy in the mail, and then I also get to look at it online. So just something to consider. Okay, so my personal tidbit this week. First of all, I hope everyone had a good Independence holiday. They kind of canceled the fireworks where I live in Orange County, in South Orange County, California. But if you looked at the news, for apparently LA County was not paying attention, and they had more fireworks than any other place, they said, any other city, anywhere. And it was all people getting their own fireworks, which obviously is not exactly safe. But to me, it was just amusing because everybody's just so defiant right now. They're just like, we're so sick of everything. So what I'm doing is I usually get to take my vacation in September when I'm asked to speak at the AAPC Hawaii Regional Conference. And that was switched to virtual. Sort of. Well, what happened, it was canceled and moved to next year, but I have done 3 different virtual on-demand webinars for them, and they're so nice. I love the Hawaii people; they're so great out there. And so I don't get to go on my vacation this year. And my daughter, as you know, is an English teacher, so we are kind of losing our minds with all the news that we look at and social media. And we both are trying to get off our phones and just unplug. So we're heading out of town to Napa for 4 days, and so I'm actually recording this in advance so that I can be all caught up. And it's funny because we have 23 counties that have been shut down in California, but guess which one isn't? Napa. It could be because our governor owns a winery up there. I don't know, which is kind of rude, but whatever. So we will definitely practice our social distancing, probably be sitting out on a patio seating for the most part and wearing a mask into any tasting room and then taking it off only to enjoy my wine. So I'm excited about that, at least just to unplug a little bit. So I hope everyone has had or gets a chance to do something that resembles a vacation this month. Just remember that the Cleveland Clinic says that anything in water, like a pool or a beach, has little or no risk to you for COVID. So don't forget that, but make sure you also remember your sunscreen. So have fun, everyone. Hopefully you have a couple of weeks or at least a week this summer to do something well. So I will see you next week on this Terry Tuesday. Thanks for spending some time with me. Make it a great day and a great week. And thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.